Good morning, everyone. Welcome, and really thank you just for joining this morning, just to listen to my talk. I really appreciate your time. And what I hope to do during this morning is give really key updates really in diabetes. I think it's been a really exciting decade in diabetes care in terms of where we've come from and where we are. There are challenges, but with developments and where we are in terms of the new developments that have come on board, there really is an opportunity to be able to really address those challenges in the future. I don't have any disclosures. And what I hope today really is, there are three key objectives really what I want to do. I think more than anything is review the key parts of the American Diabetes Association standards of care and key literature updates as they apply to patients with type 2 diabetes. I'm a big fan of goal setting, as I know many people are in diabetes care, and discuss really, focused approach to that. I will discuss some of the optimal use of technology. There's been a lot of changes in technology in diabetes, and also just close by giving some examples of the work done with diabetes education in my role in Arkansas as well.
Peter, can I interrupt for 1 second? We're getting feedback that you're a little hard to hear, so maybe just sit a little closer to your mic.
No, thank you. Yes,
thank you.
Is that better? Can you hear me now? Yeah.
It seems to be, yeah. Thank you.
Great, thank you. Yeah. So thank you very much. So in terms of optimizing, first of all, just a general background in terms of diabetes and obesity management. If we look at the CDC prevalence, and this map essentially shows prevalence of diabetes and obesity starting in 2004. And if you look in the bottom right-hand corner here, you can see patients diagnosed with diabetes or obesity. And dark green is essentially high prevalence rates of obesity and diabetes. This is 2004, moving through 2010, finally into 2016. And I think this is very striking that literally over a very short time frame, we've seen a significant rise. And this is on the background of rises also in previous decades. There was a report last week from the CDC, a press release, which really outlined a concern that there was a doubling in the number of states with high obesity rates from 2018 to 2020, so more than 35%. And the last time a state had gone into that higher bracket was actually 2012, so a really significant rise. Big impact of this on healthcare. But, topically, thinking about COVID and what's been happening, we know diabetes and both obesity are big risk factors for our patients. A lot of us have seen inpatients with hypoglycemia. We've seen patients with obesity at higher risk. The reasons underpinning this are multifactorial. It comes back to nutrition, physical activity, underpinned by stresses, social and economic. And this is going to also have an impact on those previous prevalences in terms of the amounts of diabetes cases we see. So a little bit about, being topical, a bit about COVID and diabetes, because a lot of us have seen patients in these situations. And this is actually a study that looked at the entire population of England, so 61.4 million population, whole population study of risks of in-hospital death for patients admitted with COVID-19 between March and May of last year. And essentially what it showed was that if you have type 2 diabetes, your risk of death was double that of the general population. It was higher for type 1, 3.5 times. And even if you adjust that for previous hospital admissions, previous history of heart disease or cerebrovascular disease, the risk is still 1.8 times that of the general population, which is a real concern looking at our prevalence rates that we're seeing. So it's good just to think about, thinking about those obesity graphs and, the diabetes prevalence and rates, what's happening at the level of the beta cell in these patients, take it down to the individual. And we know that prior to the diagnosis of diabetes, at year 0 on the x-axis here, there's this history of pre-diabetes, which affects, a good 40% of the population. It really is a big driver. And we know that initially we see this rise in post-meal glucose, then fasting glucose. And essentially this is driven by this insulin resistance, this other term we use, the Starling curve of the pancreas, which is this failure of insulin secretion. We talk about also the incretin effect as well related to GLP-1 hormones. But essentially by the time someone's diagnosed with diabetes, they may have lost as much as 50% of their beta cell function. So we're already, can be facing a beta cell which is struggling at that stage. I think it's always good just to recap on what we're trying to achieve with A1C. We know it's more than just a number. We want to try and communicate that in our sessions with our patients. And actually, one of the earliest studies, UKPDS, tells us that 1%, reduction in A1C, we can see up to a 37+% risk in microvascular complications. We're going to see an impact on deaths from diabetes, but also impacts on cardiac disease and peripheral vascular disease. Thinking about those effects on macrovascular disease, I think it's important to say that we can really have an outcome there, a positive outcome there as well. Looking at, where we are right now in terms of our patients with diabetes and how well we're doing. So generally, this was a study back in 2016 looking at patient reports of the care they're receiving. About 3/4 of patients reported having one provider who was their primary source of diabetes care. I think this is a big one. Physical activity, only 1/4 of patients were reaching the 150-minute per week goal of physical activity. About 3/4 reported attempts to lose weight. And then in terms of statin therapy, about nearly 60% of patients with type 2 diabetes reported being on statin therapy. In the same report, looking at achieving all of these goals for patients, and the ABC goals, definitely there is potential to improve on these numbers in the future. And if we look at the ABC goals for many adults, and we can take either a stringent A1C goal of less than 7% or less stringent of less than 8%, and I'll talk more about that in a moment. But, for those, even for the less stringent goals, only about 36% of patients were achieving those. So again, I think a real potential to get that better for patients with type 2 diabetes. So that's just a general background to paint a picture of, the prevalence, where things are. And I think, what I want to do, now in the main body of this presentation is, start by talking about recognizing the problem, first of all, and screening, and really how, we get those basics right, first of all. So it's always, this is often a common exam question as well, a common board question, but actually asking about screening for type 2 diabetes, when should we start screening? And, taking the American Diabetes Association guidelines, they recommend testing at 3-year intervals or more frequently, depending upon the individual, in all adults with a BMI of greater than 25 or greater than 23 in Asian Americans with at least one risk factor. And that could include either an A1C, a fasting glucose, or a 2-hour glucose tolerance test. In practice, it's going to be one of the first two because the last is more challenging to organize. If we look at individuals without risk factors, someone who's falls in a low risk group, then age 45 is when screening should start. So it's just good just to talk about those initial definitions first. Who's at risk? Who are the people who would be considered at risk in terms of risk factors? So some of these you would expect. So 1 and 2 would be, there's first degree relative. We talked about higher risk communities, Pacific Islanders, Asian Americans. And I'll be talking a little bit about the work I do with Pacific Islanders. Also a history of hypertension, dyslipidemia, but also polycystic ovarian syndrome. And I think if you look at number 8, physical inactivity, and think back to that previous slide where 25% of patients were reporting not doing the exercise per week, you can see that's a big proportion of individuals. For patients with pre-diabetes, it's recommended once that's been diagnosed, they should be tested yearly, and we should be targeting those individuals for interventions. Gestational diabetes should result in lifelong testing, and as I say, 45 years is the cutoff that we take. With repeat frequency depending upon other risk factors as well. And just to recap on the numbers, I think it's always helpful to do this. Again, it's what are we looking for these individuals? And I think we all know 126 is the cutoff for the fasting plasma glucose for diabetes. This for pre-diabetes, 100 to 125. I think it's really helpful if we have someone with pre-diabetes really to highlight that in our sessions with them, so they can make steps to make those adjustments as well. And I think also the A1C can be extremely helpful in the clinic setting, for the non-fasted patient to get information as well. The oral glucose tolerance test, as I say, we do less frequently, but that just recaps on the values here as well. And so for a post-glucose load, normal post-glucose load at 2 hours would be less than 140, with 200 or higher being consistent with diabetes. So that's about screening. What about, the real important bit, which is setting goals, setting glycemic targets for individuals as well. And, I make no apologies for this. I think these 4 basics, I think, are the key in managing diabetes and helping get individuals on track. And I think if these 4 cornerstones of diabetes care are in place, the individual will get the right outcomes. For all 4 of these, we all know that it's sometimes a little more complex. There are many other factors which can impact these at the individual level. But if nutrition, physical activity, glucose monitoring, and medication adherence are in place, then we're going to get the right outcomes for that individual. In terms of goal setting and, setting goals for lifestyle, and thinking about those cornerstones of care, nutrition, we know that actually focusing on weight management, looking at calorie restriction where appropriate, structured counseling, use of nutrition, sometimes use of meal replacements as well, can be very helpful. But I think more than anything, we know that a one size, fit all approach doesn't always work. It really is tailoring it to the individual and getting an understanding of their own individual needs. Physical activity, so going back to the original DPP trial, which showed us that 150 minutes a week was effective for preventing progression of prediabetes. That is a standard recommendation for many patients. And really trying to encourage everyone to build that up and push on physical activity and set goals around that, I think is helpful for people. You can see I've mentioned sleep, behavioral support, and smoking cessation. So sleep is one that often, it can get squeezed out by the others, but obstructive sleep apnea is common in many of these patients and will impact glycemic management. And that can be a concern. We know that with behavioral support, our patients with diabetes have 3 times the risk of depression than those without. And again, that can have a huge impact in terms of the patient who is apathetic about treatment. There've been many things which are impacting their ability to monitor and test. So diagnosing that early and treating can also have a significant impact. So as I said earlier, lowering A1C can have a big impact for these individuals. And I think, again, communicating this at the patient level, it's not just this number. You've cut your risk so much by lowering your A1C, your risk of these complications of kidney disease, eye disease, and neuropathy are really much improved by making these changes. What about diabetes control and getting tight glycemic control and the longer term effects on cardiovascular disease? So this is an important area because we know that in terms of achieving the benefits for the heart, it really takes time. The EDIC study actually followed patients who were originally in the DCCT trial, who were either the intensive or conventional arm. And what we found that was really to see those cardiac benefits, it was taking at least a decade for the intensive arm of that trial. What does that mean in practice? So, it means that, early good tight glucose control when appropriate in the patient who can tolerate that well is going to actually lead to long-term positive outcomes with regards to reducing non-fatal MI, stroke, and cardiovascular death. And that's the key message that comes out of this, really. And the risk reduction is significant. So we're talking about a 57% risk reduction for those individuals further down the line in terms of A1C. So for the standard adult, when we see someone in clinic, what are we wanting to set as the goal? And, one thing, we like to do in the diabetes program is always, send people away with goals, but make those goals achievable as well. And so the ADA would say that for the standard person with diabetes, with type 2 diabetes, a pre-meal goal of 80 to 130, post-meal of less than 180, with an A1C of 7% would be the target for a majority of adults. And that's going to keep them in the low risk group. But it's not always as simple as that. And particularly for older adults over the age of 65, we need to create really something that's more individualized and think about things for that individual. And that means often setting targets and goals which are safe, which achieve what's required, but that individual can follow as well. So for a healthy older adult with few existing chronic illnesses over the age of 65, a reasonable A1C goal of 7.5% is absolutely doable. Versus someone who's got heart disease, cognitive impairment, we're going to be setting that goal higher. And the reason being is we know that hypoglycemia, which I'll be covering, is going to have more of a negative effect on that individual. And again, being practical about that is important, avoiding hypoglycemia. And then for those individuals then with really complex poor health, end-of-life care, really, again, thinking practically about setting those goals, often in the higher hundreds range, so that, again, we minimize risk. So it's about creating an individualized plan for that person with diabetes that's safe and effective. Thinking about those patients as well, it's good to talk about our glycemic targets when we see someone on the consult service, on the glucose, on the inpatient service as well. And everyone on this is well aware that for a majority of inpatients, a target glucose of 140 to 180 is recommended. For the majority of critically ill and non-critically ill patients. And essentially that we know that if we can achieve that, we're going to, really strike the right balance. Very occasionally, it doesn't happen as often, but we may have patients where more stringent goals are appropriate, although the evidence for that is less strong. But there are some patients where we may wish to achieve that. And finally, an important plug for our inpatient diabetes consult team as well. I'll be talking about shortly. And really, if you have a patient with diabetes where there is a struggle, etc., we're really keen to be able to support the primary team in managing these patients as well. So for an inpatient with diabetes, I think the key thing to ask, often, and this is challenging because there's multiple things going on, but it's always good to have in the background is this patient going to have to learn anything before they leave? And in particular, I think the challenge is, and it's hard to sometimes realize this, but learning to inject insulin actually requires about 13 steps. So for the patients who's, in hospital, a lot happening, their bandwidth is going to be taken up by other factors, that can be a challenge. I would definitely say for those patients who are requiring those extra steps that, consult through our endocrine team, and we can arrange for our team to then see the patient. You'll occasionally get one of our team members also reaching out maybe on a patient who's known or who has glucose levels above goal, what we call our inpatient glucose monitoring service, to actually really support those individuals. Insulin education itself actually really does take time. There's first of all the kind of what's going on, there's the condition, there's the hospital schedules, the tests and procedures which can interrupt teaching. And actually, particularly as you get to the last day or the day before, people are more focused on discharge and are going to be often less receptive to that detailed teaching. They may, but there's so much happening in that day before discharge. And as I say, just learning to use the glucose meters, insulin, really requires, good intact executive functioning skills, several steps, and a little bit of time as well. And I really would like to, really highlight our inpatient glucose monitoring team as well. That's Ella Ares and Francisco Diaz, who you'll see, rounding. And, both of them are extremely approachable and very keen to be there for your patients with diabetes who need help. And as of November, we will also have an additional team member, physician assistant, joining at MSW, who will complete the team as well, so we can, really provide support, where needed. I definitely say for best results, to order the endocrine consultant early in the hospital stay is ideal. If you involve us early, in fact, the studies support this, we'll definitely shave some time off that length of stay. If we get called the day of discharge or the day before, we'll probably lengthen the hospital stay. We don't want to do that. We want to shorten that stay for that patient. So definitely, you know, the evidence is strong to say that an early consult can really impact things positively. So moving on, you know, and setting goals for our patients with diabetes. And there was a really nice article in the New England Journal, actually this year, 2021, on actually where are we with comprehensive risk factor control for these patients. And what do I mean that? Well, I'm focusing very much on the hypoglycemia, hypertension, and dyslipidemia in terms of where we are, and really what's happened over the last 10 years for these patients. And so looking at that here and, you know, where things are right now, and this is looking at trends from 1999 to 2018. And if you look in the top left here, first of all, just general glycemic control, we saw a steady improvement. And now the yellow line is a target A1C of less than 8 and blue of less than 7. So more stringent, less stringent goals. We saw a leveling off, maybe perhaps a little bit of a dip. And, you know, the reasons for this are not quite clear, but there was definitely a leveling off over the last decade in terms of hitting those targets. For blood pressure control, a similar theme in the top right. The bottom left, then lipid control, we seem to have reached a plateau. About 55% of patients with diabetes who are appropriate for statin therapy on that. And when we look at the bottom right here, all risk factors combined, it means just about a quarter of our patients are hitting these goals. So I think definitely there's a real potential to see these figures improve and really focus on improving this in years to come. Looking down at the level of the individual, and this is looking in the same study as well, trends in glucose lowering medication between those 2 decades as well. So there was definitely a steady increase in the first decade with then a leveling off. Most of that increase came from metformin. We saw a decline in sulfonylurea use, an increase in insulin use, and in more recent years, and I'll be talking about this, I think this is exciting, I think an increase in the use of SGLT2 therapy and GLP-1, you know, as we've ended up having really good quality primary endpoint data for these treatments. Similar themes with blood pressure lowering medication and lipid lowering medication as well, but so more of a plateau in terms of the last decade that we've seen. So, you know, in terms of those goal settings, this data from NHANES has shown that this leveling off over the last decade, as I said, the reasons are not quite clear, but the main concern might be that we may see this herald increasing complication rates over the next decade. And a real, I think, when we're goal setting, I think for the individual patient, and I'm all for this, is saying, educating the patient about achieving these goals and their importance as well, because, you know, I think an educated patient is definitely a proactive patient, and that can make all the difference. So that's goals are important. And what I'd like to then also move on to next and cover in type 2 diabetes is about hypoglycemia, you know, particularly some of the recent updates and what we're trying to achieve in terms of, you know, minimizing the risk of hypoglycemia as well. And so this is a practical case I'd like to give just now. Someone who actually came to our clinic was a 62-year-old male. He was an outpatient consult that we saw for diabetes assessment, quite fluctuant glucose levels. And he was on a fairly straightforward regime of Lantus 55 units and metformin 1 gram BID. And he was complaining of multiple low glucose levels. He'd had one less than 70, one of 53, but he was not getting symptoms at those times. So essentially unaware of those symptoms. His A1C was 8.9%, his BMI was 24.7. And so what we did for him was as well as doing his testing, was also apply a continuous glucose monitor. And what I think this demonstrates quite nicely, you can see this, is if you look at the x-axis, so it goes from midnight to midnight. So every night he was going hypoglycemic, as low as 40, and was not waking up. So this is a real concerning situation. And that's happening night after night. And then through the day, so we know that once you've had that hypoglycemia, you're going to have these secondary hormonal responses, a rise in cortisol and growth hormone levels, adrenaline levels as well. And those effects can last some hours after the acute event. So, of course, then there was a tendency to consume more carbohydrates through the day. So some of his glucose testing was showing these big spikes in glucose. But what this shows is just a couple of points of tests in time may not tell the full story. And I think that's where a continuous monitor, particularly for a patient like this, can be extremely helpful. And this term has been applied and it's a bit of a mouthful. It's over-basalization, which essentially means too much basal insulin. And I think using common sense with these patients, that's exactly what we did. We cut back his basal insulin. But what are the clinical signals that may prompt evaluation of this? So it may be if the basal dose is more than a half of a unit per kg. So that's at the high end of normal. We talk about a bedtime morning differential. What does that mean? So if someone goes to bed at blood sugar X and wakes up with blood sugar Y, and there's more than a 50-point difference between the two, that's a high differential and suggests over-basalization. I think asking about symptoms of hypo-unawareness, and then finally just a high variability. As you could see from those continuous monitoring there was huge variability in his glucose levels. So over-basalization is something which it's important to recognize and is quite critical. A little about this patient's hypo-unawareness as well. So we know that he was not perceiving those symptoms, and this tends to occur more in type, specifically if we have it in type 2 diabetes. It's dependent upon the duration of type 2 diabetes and also in the more elderly patient as well. And the real concern with this is that if someone has this, it's going to potentially lead to an extremely severe episode, which could result in loss of consciousness, brain damage, seizures, etc. And the management is straightforward. So it really is about looking at short-term relaxation of targets and really, again, adjusting those goals. And this can often be a challenging conversation for someone who's had very tight goals for many years, and then saying, look, we want you to shift these goals. This is critical. And getting people to change their mindset, because that's the only way this is going to be fixed. Avoiding hypoglycemia, it has been shown that if you really cut the treatment back and allow the glucose levels to run high, a lot of patients will regain awareness of those symptoms of hypoglycemia as well. So hypoglycemia itself, I think, when we're defining it, it's always good to know what the definitions are. And, as many are aware, the biochemical cutoff for hypoglycemia is a glucose of less than or equal to 70. In recent years, we've moved to this term of clinically significant hypoglycemia for a glucose of 54 or less. That doesn't mean that that's less than 70 isn't significant, but it means that at that level, we're more likely to see serious clinical effects on the patient, confusion. We know that hypoglycemia has a significant effect on the myocardium and can actually cause prolongation of the QT interval. And that's felt to be one of the mechanisms by which we can see fatal dysrhythmias. And finally, severe hypoglycemia. So we call level 3 hypoglycemia now, where we can see where the need for third-party assistance is there. And all of these, I think recognizing these early on is critical to prevent progression. How common is this? So if we look in type 2 diabetes, 1 in 9 patients will report 1 severe hypoglycemic episodes per year. In terms of how often they will go to the emergency room, about 1 in 100 of those will attend the emergency room of patients with type 2 diabetes. And although it's more common in type 1 versus type 2 because of the prevalence of type 2, majority of patients that we see attending with hypoglycemia will be in type 2. And we've seen a steady rise in hypoglycemia hospitalizations, particularly in younger patients, although interestingly in patients over the age of 65, there was a bit of a dip early in the last decade, and perhaps as a recognition of the need to move to more practical targets in people in the older adult. So in terms of harms with hypoglycemia, there's significant harms. There's, first of all, quality of life and fear, anxiety. And it's been shown that for a patient who's had 1 severe hypoglycemic episode, that can affect their diabetes, how they manage their diabetes for up to 12 months plus after the acute event. So it's not just that point in time. There's essentially a response which lasts beyond that. So it really can have a real negative impact on how someone manages their diabetes. I've talked about unawareness. Falls and fractures in the elderly can be a concern. Dysrhythmias for the patient, maybe with mild cognitive impairment, it can result in worsening of that, and in more severe cases, mortality as well. So, a real challenge. And what about this concept of hypoglycemia unawareness? So the other term that's been used for this is hypoglycemia-associated autonomic failure, but essentially at the level of the brainstem, the glucose receptors. We know that for someone who's having multiple low glucose levels, that ability for those receptors to respond becomes impaired. And as a result of that, we see an impaired adrenaline stress response as well. We know there are other factors as well, obviously, in terms of the excess insulin, a reduction in glucagon as well. But what this means in practice is that for someone who is unaware, they have a risk of having recurrent severe hypoglycemia of, from the studies of 25 times or more. So real massive increase. So that's why I think hypo-unawareness it's a really good question to ask someone. Each visit is say, when you are low, or if you are low, what kind of symptoms are you getting? To make that diagnosis of hypo-unawareness, so we can take that action as well for those patients. At the level of the individual with hypoglycemia, and we look at this can be either in the ambulatory setting or when we see an inpatient as well, we want to think, what are the factors that are going to put them at risk? And it does boil down to insulin, glucose, carbohydrates, with a number of factors impacting that. So particularly, for the patient who has, poor nutritional status, missed meals, physical activity, other factors that could be driving too little glucose versus, being on excess dose of insulin. A real common one is mistiming the dose of insulin. And then, for a more elderly patient, that impaired counter-regulation, if they've maybe been fasting or eating less for a day or two, potentially you've got someone who is immediately going to be at high risk. And, just making some adjustments for that is key. Yeah. At the global level, thinking about hypoglycemia, we look, looking beyond the individual, so diabetes duration and glycemic variability, that's diabetes complexity. We also want to think, as I say, about, comorbid conditions at number 2 here, and other factors which are going to put them at risk. Looking at number 3, looking at polypharmacy, other medications which may impact this, higher risk medications such as insulin, sulfonylureas, just medication, what we call medication misadventures. So having a discordance between meal timing and insulin as well, which can happen. And then there's the patient context environment. So health literacy, other factors which may impact that, caregiver support, fasting, and being culturally sensitive to the individuals where there may be other reasons for fasting. And then finally, within the system level, I think it's important one is if we have benchmarks saying we want to target an A1C of goal of less than 0.x, that can also drive an increased risk of hypoglycemia as well. So that's where having these fixed targets can really help for individuals. So looking at the elderly population with hypoglycemia, we know that, as I say, they are going to be a much higher risk. And the Accord trial that was, it's a few years ago now, but some may recall that one of the goals in this trial was to target an A1C of 6%, and the trial was stopped early due to an excess mortality rate. And what we found was that for patients in the intensive glycemic control arm, there was an increased mortality rate. And when we looked at frequency of patients being impacted, it was the older adults in the 70 plus age groups who were more disproportionately affected. So again, emphasizing, protecting the at-risk population. For patients with type 2 diabetes as well, and when we look at A1C for that individual, again, we've got to be mindful that as the A1C, if it's below 7, we're going to see a rise in hospitalization risk, particularly as we go down to 6 or less. And that's, can be an exponential rise. And that's really important as well, I think, in terms of minimizing the risk for those individuals. What about precipitants of hypoglycemia? So in terms of the individual, we know that actually the commonest reason are meal mistimings with insulin, taking the wrong dose of insulin, unintentionally taking the wrong dose, or confuse the units. And that's about 3/4 of patients who come in with hypoglycemia. So a significant proportion, that is the trigger. And on hypoglycemia, what would I say? I would say definitely doing an assessment of these patients. It's not always asked in the clinic setting because we're focused on the other targets and everything else, but just asking about this because people may not always volunteer it. It's been shown that only about half of people who had one severe episode where they needed third-party assistance volunteered that information to their healthcare provider. So that's helpful to know of. In terms of how we prevent it, definitely the level of the patient education is helpful. This just describes a group education program that I worked on previously, which essentially is providing structured education at the level of the group within a group, but also at the level of individual. Really having patients who are almost who are experts about their condition, proactive, and are really focused on being able to adjust insulin and carbohydrates around meal times. And that has been that was shown as in terms of an intervention to be able to benefit both A1C and quality of life and reduce hypoglycemia as well. And at the level of the individual patient, again focusing on individualizing targets and really setting goals of that are going to be practical for that individual as well. At the level of the American Diabetes Association guidelines, they actually now have a section on this, and what are the treatments which are going to minimize risk of low glucose. And I think beyond what I've said about thinking about insulin and sulfonylureas, we're always going to ask: can the insulin be stopped? Can we use an alternative? Can we simplify the insulin? Can we stop the sulfonylurea? Can we use an agent which is less likely to cause a low, such as an SGLT2 or a GLP-1 or a DPP-4? And just by having those thoughts, we can definitely cut the risk for these patients as well. So enough on hypoglycemia. I think next what I'd like to do then is talk about, one of the new developments, which has really, I think, grown very quickly in the last decade. And, you'll see more patients now using technology for their diabetes. And just wanted to give a general overview in terms of, some of the key developments over the last 10 years. And how they can apply. So I really like this. I think, again, there's a really important point to be made when we're using technology is it's important to keep it straightforward. It's important to think, okay, what are the literacy and numeracy levels of the individual? How can we implement this in a way that it's going to be manageable? It's been shown that, up to a quarter of patients may have difficulty just even interpreting what's going on with the meter, calculating carbohydrates, dosing insulin. It's what we call numeracy and literacy skills. And that is strongly associated with A1C and self-efficacy in a body of research that's out there. But thinking about technology and advances, going from the, one of the earliest insulin pumps here, which was backpack size, we've now got these, extremely miniaturized devices now, which have transformed things for patients. And that's been exciting in terms of, providing more opportunity for diabetes care. We have 4 real main groups of insulin pumps that you may see out there right now. In the top right-hand corner, the Omnipod Dash, which is quite popular with patients because it's what we call a tubeless delivery system. The insulin is kept inside the pod. At the bottom left, we've got the Medtronic pump, which actually is combined with with a continuous glucose monitor and will constantly try and steer the glucose to 120 in these individuals. On the bottom right, the Tandem T-Slim, which also links with a continuous glucose monitor and has the ability to steer that glucose to target. And in the top left corner, actually a disposable patch pump device, which actually has less settings, but actually can be useful in some patients as well in terms of being able to produce a steady delivery of insulin. Continuous glucose monitoring technology has likewise been helpful. We have to be mindful in terms of accessing this for a majority of patients. We can prescribe it only for those on 4 doses of insulin per day, and that is related to coverage. So particularly, in terms of getting prior authorizations for these devices, that is one of the requirements in terms of the individual. But in terms of where it's leading us now to this new point where we're seeing for patients with diabetes what we call an ambulatory glucose profile. So, we're taking the A1C. We all know there's a bit more to diabetes than the A1C, but we're thinking what's happening at the level of their glucose control on an hour-to-hour basis. And we now can use the term time in range. And the goal for time in range, and by range, that's a range for a majority of people of less than 180 and greater than 70. If someone's at 70%, their A1C will be 7% or less. Where this is helpful, and just showing this one here, as you can see in this slide at the bottom of the colored bar there, this patient's having a significant proportion of hypoglycemia, about 5 or 6%, and that's going to be important to find out when that's happening so we can stop that for the individual. So time in range itself is a really helpful measure. If we see a shift from this 70%, 10% either way, that's going to potentially add or subtract 0.5 from the A1C. But it's particularly useful, going back to what I was saying about hypoglycemia, for picking out those patients where there is a problem. And the technology is going smaller. So looking at one of these companies that makes this technology. So for example, Dexcom, on the left, you have what we call the Dexcom G6 sensor. And then in development, the G7 sensor, which is about the size of a dime, so less obtrusive for the patient. So really, there's a move towards making this much easier for the individual in terms of managing their diabetes. In the pipeline for diabetes care, thinking about technology and new developments, we have a once-weekly insulin likely to be released in the next couple of years. That's insulin icodec, which will really help for individuals, who in particular social care settings. We have treatment called the twin cretins, which is a treatment which works on both GLP-1 and GIP receptor to improve control, and some really good data coming out on those. And then finally, new pump and continuous glucose monitoring technology as well. So as I move into the closing parts of this just now, I'm going to just run through some of the ADA standards in terms of what we're aiming for our patients. And as I've alluded to earlier, it is about individualizing care, considering the individual at the level of comorbidities and disease duration and risk in terms of setting those goals for A1C. I think the big key thing in the last 2 decades has been the number of great trials we've had which have looked at cardiovascular safety for diabetes drugs. And this has led to really great endpoint data, which has completely transformed our models in terms and guidelines. And this goes back to, some time ago, concerns with the glitazone class of medications and cardiac effects. And as a result now, we've actually got all this data for GLP-1, SGLT2s, which has really transformed what we do. And this just summarizes some of the endpoint data for SGLT2 and GLP-1. And I've underlined some of the primary outcome data here on these slides, just overlapping to the GLP-1, SGLT2 effects. But if we take SGLT2 on the right, we've got great endpoint data, as many people are aware, for heart failure reduction, hard renal endpoints. If we take both together, there's good evidence that both GLP-1 and SGLT2 can reduce the risk of major adverse cardiovascular events, but we still have also the secondary endpoint data for more broad renal endpoints, cardiovascular death, and also reduced stroke for GLP-1. And that really, in the last few years, has actually transformed that evidence base has transformed our guidelines. And these are the guidelines as they are right now. It's beyond metformin, it's thinking, what is the goal for that patient? Is it about hypoglycemia risk? Is it that we're wanting to look at weight gain, looking at the level of the individual, thinking, is there a higher risk of cardiovascular disease? So that could either be using an SGLT2 or GLP-1, as we know. For the patient with heart failure, fantastic data in terms of reducing hospital admissions and using SGLT2s there. And in chronic kidney disease, again, SGLT2s being extremely effective, reducing chronic kidney disease progression as well. I've mentioned hypoglycemia, but also good to consider where weight gain or promoting weight loss is an issue, using a GLP-1 or SGLT2, and also where cost is an issue, being practical, saying, thinking about options which actually carry less of a financial burden as well. So that's the advantage of those guidelines. So in terms of clinical inertia, it's important to say that although we have the guidelines, it's thinking how quick are we at escalating those treatments. And so it has been looked at that for someone who is not at goal, it can sometimes take between 1.5 and 3 years to escalate treatment, and that's across the board. My belief is that it's getting better, but it is one of those things that it's important, I think, to be mindful of. If we look at the factors that contribute to clinician inertia, clinical inertia, it can either be patient-related, physician-related, or healthcare-related. And again, on physician-related, I think we've covered this goal setting. It really is about setting goals for the individual and getting those goals across clearly. Patient-related can be denial, communication. It can be related to just fear, effects on literacy, depression I've mentioned. And then at the level of healthcare, looking at visit planning and a team-based approach as well, so we can make sure we get the most out of the visit for the patient. So in the closing few minutes now, I'm going to go through a little bit about some key education approaches in diabetes as well, and then have some time for questions then at the end. So diabetes education itself is very powerful in terms of A1C lowering. This just summarizes some of the key medical nutrition trials in diabetes, and what it shows on the right for A1Cs, we can see a 1 to 2% reduction in A1C for medical nutrition therapy in diabetes, and that's as good as many drugs. So that's a really key message to get across here, is that actually diabetes education can be just as good as medication. The DAPHNE trial I'd mentioned earlier looked at focusing on teaching about flexible insulin dosing and carbohydrate adjustment. And we saw that at 6 months for patients on this, we saw a significant reduction in A1C. That's the red line here. There was some falling off of that, 12 months. And that led to an improvement in terms of the program and saying, look, we really need to reinforce these principles beyond just having an initial 5-day course, which was taught by an RD and IN, and reinforcing those principles later on. Where may education impact A1C? So promotion of self-management is definitely one of the big ones here in terms of getting the best outcomes. And again, patient education as well in terms of getting those best outcomes for the individual. It's important to have a strategy for diabetes care. Some time ago now, we did a snapshot of our patients with diabetes where I worked in the southeast of England in West Kent, and we found there was a real need to do better in terms of structured education. We found that we were, the local population, there was a need to build an education model and really create a tiered system of care with primary care to actually make sure these patients came through the education and actually got the group education they needed. So, in terms of that, in terms of, where education can help, I'd just like to, finish these last couple of minutes by giving a couple of examples of, summary of some of the education work we did in Arkansas to help. So this just summarizes, 2 of the key areas which have had challenges in diabetes. So both in the east part of Arkansas and in the northwest, which has a higher prevalence population. That's also, interestingly, the site where the Walmart was founded, right there in the northwest corner. But actually, there is a population up there which also has a higher prevalence. And one of the initial projects we did was just to look at using straightforward group education in the Arkansas region. We did 2 hours face-to-face, use basic medical nutritional therapy, and then 8 weeks of telemedicine, weekly visits, getting the patient to bring their glucose levels along. And this worked well because of very proactive educators. And these were their baselines. They had A1C of around 8.9%, BMI of 33.9. And essentially we had the APN endocrinologist supporting the local site where there was the diabetes educator and really supporting the patient locally over those 6 weeks that we did this project. And we saw just within 8 weeks, it was pretty easy to impact A1C. This was a combination of education and getting people to make changes in what they were doing and seeing an improvement in those levels as well. We used the telemedicine link, which back then was seen quite a big deal. Right now with Zoom and with everything, I mean, it almost seems old-fashioned now, but it definitely helped these people. The other group we looked at, and I talked about Northwest Arkansas, was a group of Pacific Islanders who live in the northwest of the state, and they're actually the largest Marshallese population in the continental US. And since 1986, they've been allowed to live and work freely in that part of the US without a visa or permanent resident card. And that was an arrangement that was set up some years ago. They had very low rates of diabetes up until the 1950s. Their diet was very much a plant, fish-based diet. Unfortunately, during the 1950s, during weapons testing, there was an effect on their food chain, which meant that the number of processed foods in their diets, pretty much within a short time frame, changed completely, and so did diabetes prevalence, unfortunately, as well. And that led to migration, in particular within Northwest Arkansas. I mentioned Walmart, but there are a number of employers as well where people moved and emigrated to take jobs with those employers. But what was discovered was that when you looked at these individuals who'd had this very difficult time, was that they had extremely high prevalences of diabetes. So literally only about a third of the population, when being screened with A1Cs, had normal A1Cs, which was a real concern. And so, the drivers for that were a combination of lifestyle, diet, genetics, lack of health education, support, lack of preventative care, and essentially just difficulty navigating the system. They were a high-risk population with a disproportionate burden of diabetes. And one of the challenges was that just using the standard structured approach, DSME, did not work well for them. And so that's where we used a straightforward model where we thought, let's look at involving the individuals around that individual, the family, and the many definitions of family, but really getting people to come along to the education who were part of that individual's home group. And, what we found was that by bringing in people from that community to help design the curriculum and really culturally adapting it, it could really impact what we were able to do. And we did a pilot with them some years ago. And I think the key to the success was having great teamwork and support, from a fantastic team throughout there. What we found, and I'm sorry, I'm rushing through these last couple of slides, want to keep to time, but, we found that in terms of individualization, that there was difficulty around understanding of portions of food. And, there was a real problem for this group in terms of being able to make changes as an individual, because as a culture, it is seen as disrespectful to eat separately to the rest of the family or to refuse food that's offered as well. And so that was a real big thing that came out of this that was discovered. And that led to the PCORI study that we did do for these individuals, where we were able to support them and did a large trial, over 300 of these individuals, and looked at A1C and many other metrics as well. And we got the grant was from PCORI. We had over 300 participants, and we randomized them to two groups using standard ADA curriculum or a curriculum that was adjusted to this population based on the family model. And we got the community to help in the design as well. And this actually shows the result of that. And so looking at the first group, that's the series 1, that's the group who had the family-based curriculum. Their A1C fell from 10.2 to 8.85 over the time of the study. Even for the standard curriculum, the ADA non-family-based curriculum, there was a fall from 9.9 to 9.6. And then series 3 was just the family A1C that we also decided to collect data for as well. We published that a couple of years ago. So, what I'm going to do now is just really kind of summarize the key points there in terms of, what I've hoped to, convey this morning. I think it really is about setting goals for individuals. I think, and making sure that not just setting those goals, but making sure that the individual has got those goals as well and understands the relevance to them. And I think tailoring that to the level of, to an individual as well, and understanding where they're coming from. with their diabetes and barriers to care, and what can we do to help. Technology is definitely helping, and I think is going to help us moving forward. I think if the four cornerstones of care are there, we're going to get things right. And I think, if we can achieve that, I think we'll get the right outcomes for our patients with diabetes. Thank you very much. Any questions?
Yeah, thank you, Dr.
Thank you so much, Peter. Go ahead, Angad.
Yeah, thank you, Dr. Goulden. I don't see any questions in the chat, but people are.
I think we have time for one question, just with the amount of time we have left. So, Norma, if you can keep it to one, please, and go ahead.
Yeah, the question I want to ask is, in patients who have yo-yo blood sugars, what is the impact on the variation in blood sugar throughout the day from low to quite high as 700, have an impact on the ability of them to metabolize medications for comorbidities, heart failure in particular?
Yeah, no, I think that's very fair. I think so. What we're referring to there is glycemic variability. So that patient who's moving back and forth between low and high levels of glucose, a bit like the example that I showed there with the patient who was referred to our clinic, where I showed the continuous glucose monitoring, and you could see major yo-yos. So essentially, low overnight, high in the morning. In terms of that, how that may impact, the rest of their treatment. So if you think at the level of glucose, the effects of that, we see an excess. It has been shown that increased glycemic variability in the studies is associated with excess mortality. We know that when they're hypoglycemic, there are effects on the myocardium. I mentioned the effects on the QT interval, on the EKG. And so what you could envisage is, for your cardiac patient who's on a beta blocker, that would not be, the best of interactions, or for someone who's on amiodarone. So glycemic variability itself is potentially, although it's in terms of interaction with the drugs itself, it's going to be via, I would say, those types of mechanisms rather than directly. But we know it is associated with an increased mortality risk, and is something we should be looking to really address in our visits. Yeah.
Thank you.
Thank you. There's another question in the chat. So Kirtana, one of our PG/2, says, thank you for the excellent talk. The US PSTF recently lowered the age for routine screening to 35 years. What are your thoughts regarding this versus the ADA recommendation of 45 years?
Yeah, so I think it's a good question. So I think in terms of that, the ADA, although they say 45 for routine screening, and they have stuck with that for now, I would say that they argue that for anyone who falls into any type of higher risk group, and particularly, anyone who falls into that BMI category that I mentioned, that we should be screening those as well. I think, there's going to be debate in years to come. American Diabetes Association is often seen as one of the key drivers of this. If we look at the European Association for the Study of Diabetes, very similar in terms of guidelines as well. And I suspect we'll see some debate. Interestingly, we had a debate, not so long ago about A1C as well, and this 7% and then 8% with other groups. And I think that leads to healthy debate.
Peter, thank you again so much for a great talk.